Welcome back, everyone, to part 3 of our 150-part IPDRG masterclass right here on Decode Healthcare with Harshal. I am absolutely thrilled to have you with us as we dive deeper into the nuts and bolts of inpatient coding. Now, before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. All right, today is all about the detective work. We're focusing on interpreting ancillary reports and the MAR to capture those complete, highly specific diagnoses.
So, here is our roadmap for today's explainer. We're going to start with a really quick recap, establish the golden rule of ancillary tests, and then jump right into interpreting laboratory data. After that, we'll cover radiology and EKGs, review the MAR, and finally wrap it all up with a summary and a little sneak peek at Part 4.
All right, let's get right into Section 1, Introduction and Recap.
If you remember from Part 2, we spent some time learning how to navigate the inpatient chart. Just as a quick refresher, the face sheet gives us our initial and principal diagnoses, right? Then the history and physical, or H&P, is where we spot those chronic conditions and risk factors. The discharge summary absolutely must match your final coded diagnoses perfectly for compliance. And those daily progress notes, well, they support the sequencing of all those conditions. These documents are essentially the core of your patient's clinical picture.
Moving right along to Section 2, the golden rule of ancillary tests.
Okay, so here's a massive paradigm shift you have to grasp when moving from outpatient to inpatient coding. In the outpatient world, pretty much every single lab test, X-ray, and EKG gets its very own CPT or HCPS procedure code. But inpatient coding, yeah, it's a completely different ballgame. For an inpatient admission, ancillary tests, things like your complete blood counts, CT scans, ultrasounds, and EKGs, do not receive separate ICD-10 PCS procedure codes. Literally, zero.
Now you might be thinking, Harshal, if we aren't coding them, why on earth are we spending so much time reading them? Well, this perfectly highlights our true role as inpatient coders. We meticulously review these reports to extract maximum clinical specificity. We use all this data to specify secondary diagnoses, our CCs and MCCs, the comorbidities and major complications. These findings are an absolute goldmine. They help us spot documentation gaps, which lets us trigger compliant physician queries and accurately capture the true severity of the patient's illness.
Which brings us to Section 3, Interpreting Laboratory Data.
Check out this actual lab report we pulled from our source files. Look right in the middle there. It's a urine culture showing greater than 100,000 Escherichia coli. Think about it. If a doctor just scribbles urinary tract infection on the face sheet, well, that's a pretty generic code. But you, as an astute clinical coder, review this lab data, you spot the E. coli, and boom, you've got the exact infectious agent. As long as it's properly linked in the documentation, you can confidently code that specificity, turning a basic, run-of-the-mill diagnosis into a highly specific code that actually reflects hospital resources.
And let's look at how this deepens your understanding of medical management. Right below that culture result, you're going to see a list of antibiotics marked with an S or an R. S simply means the bacteria is sensitive or susceptible to the drug. R means it's resistant. So, if a physician started the patient on an antibiotic that's marked R, they're almost certainly going to discontinue it and switch to one marked S. Tracking these exact medication changes in the progress notes proves there's active treatment of a condition, which totally validates it as a codable secondary diagnosis.
Let's shift gears a bit. Section 4, Radiology, EKG, and Clinical Correlation. I want you to imagine you're reading an X-ray report, and the radiologist clearly points out a severe fracture displacement. Or maybe you're looking at an EKG that shows the exact location of an acute myocardial infarction. But you check the attending physician's notes and they just say fracture or chest pain. So here is a challenge for you. Can you, as the coder, just bypass the attending physician and code that displaced fracture straight off the radiology report?
The answer is a resounding no way. This brings us straight to the clinical correlation rule. Look, we are exceptional coders, but we aren't doctors. We cannot clinically interpret abnormal lab or radiology findings all by ourselves. If an imaging report shows a condition that isn't clearly documented in the physician's progress notes or discharge summary, we simply can't just slap the code on there. Instead, this kind of inconsistency is the absolute perfect trigger for a clinical documentation improvement or CDI query. We have to ask the provider to establish that explicit clinical link in the permanent record.
All right, moving to Section 5, Reviewing the MAR.
The Medication Administration Record, commonly known as the MAR.
This document is filled out by the nursing staff, and it tracks exactly what medication was given, the dosage, the route, and the precise time it was administered. Notice here how IV Ansef, which is an antibiotic, is being administered every 6 hours, right alongside some PRN Tylenol for a fever. This MAR is undeniable, rock-solid proof of active therapeutic treatment.
And this is exactly why the MAR is basically a coder's best friend. It is absolutely loaded with clues. Take a look at this table. If you're scanning the MAR and see IV insulin being given daily, but nowhere in the chart does the doctor explicitly write diabetes mellitus, guess what? You've just found an undocumented condition. Seeing IV Lasix, that might point to undocumented heart failure. And IV antibiotics are a massive red flag for an active infection or sepsis. When you spot these clues, your next move is to initiate a compliant, non-leading query asking the physician for the underlying diagnosis that requires the specific medical management.
But I do have to give you a pretty critical warning here. While we absolutely use the MAR to track these therapeutic interventions and validate diagnoses, the actual physical act of the nurse administering IV fluid hydration, pushing an IV antibiotic, or handing out oral meds does not get an ICD-10 PCS procedure code. These actions are considered standard general nursing care. Remember, we use the MAR for clues, not for procedure codes.
Let's wrap things up. Section 6, Summary, and Part 4 Teaser.
Let's quickly recap our actionable steps for today. Step 1. Never assign PCS codes to inpatient ancillary tests or routine nursing medication administrations. 2. Always dive into those lab cultures and sensitivities to pinpoint the exact specificity of infections. 3. Keep the clinical correlation rule in mind. You must validate any abnormal radiological or lab findings with explicit written physician documentation. And 4. Always scan the MAR for those medication clues to trigger compliant, non-leading CDI queries. Doing this ensures the most accurate DRG assignment possible.
So now that you know exactly how to find these diagnoses, you need to know how to sequence them in time. Coming up in Part 4, we are tackling a massive topic, present on admission, or POA indicators. We're going to do a full masterclass on exactly when to assign Y, N, U, W, and 1. You seriously will not want to miss it. And before we go, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
To sign off, I want to leave you with this thought. Finding the clue in the MAR is really only half the battle. The true skill of a top-tier coder is knowing how to communicate that finding. If you spot IV Lasix being given but there's no heart failure diagnosis anywhere in the chart, how are you going to ask the doctor about it without leading them to the answer? Think about how you construct those queries to strictly protect compliance while still ensuring maximum accuracy. Keep practicing, keep decoding, and I will see you in Part 4.